I want you to think the sideways excursive movements like speed bumps. The more speed bumps, the more likely the nervous system doesn't like all that extra bump, 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 bump. So you want to kind of smooth out the ride when you're going left and right. Imagine you're in a car. You want it to be a little smoother. Remember misfolded proteins? If you, a human, which is rare, die of prion disease, you are a complete biohazard. They don't even know what to do with your body. Cremation is not enough. But guess what kills prions? Well, they're not alive. Guess what destroys prions? They're misfolded proteins. Ozone. Trigeminal, cervical, and this all ties into sensitive teeth because it's not just trigeminal. It's also
Most of us have the same protocol for managing sensitive teeth. We check the patient's oral hygiene, we check for acid erosion, be it intrinsic or extrinsic. We try and take care of the acid basically. Most of us are heavily recommending some sort of desensitizing toothpaste, like a Sensodyne or an Oral-B sensitive version or a Pro Relief from Colgate, whichever it may be. Some of us are scrubbing desensitizing agent into the tooth, perhaps even fluoride. And if the sensitivity is coming from like a class 5 region like abrasion or fraction, we might slap a composite in there, hoping that the sensitivity will improve. Unfortunately, have those patients who, no matter which brand of toothpaste they try, like it all helps, but they forever have sensitive teeth. I already have some patients in my mind that fall into this category. So what's going on there? Why are these patients' teeth sensitive? Well, hello there, Protrusive. I'm Jazz Galanti, and welcome back to your favorite dental podcast. For those of us dental geeks who like to spend a lot of time on YouTube, you probably already know today's guest. It's Dr. Nick Yiannios. I remember seeing his videos like, 10 years ago, 12 years ago. And I was like, what on earth is going on? This guy is using a computer to inform him about the bite. And he had all these like EMG leads on the patient. And you're thinking, what on earth is going on? I've never seen anything like this before. And then you hear about all these patients' problems, like they've got like clicking, popping, muscular pain, headaches, sensitive teeth. And by the end of the video, it shows on the computer screen what the new bite is showing. But amazingly, the patients and their response was pretty spectacular. When I look back in my journey into occlusion, and now how I'm diving deeper into digital occlusion, like using the T-Scan, for example. And next month, I myself am getting those EMG leads, flying out to America to shadow Dr. Bobby Supple, who's a previous guest of this podcast. And his podcast was called Occlusion Wars and was just a brilliant summary of the history of occlusion. You have to check it out. Anyway, Bobby's the current president for the AES, and their conference in February in Chicago is one that me and Mahmoud Ibrahim are speaking at. But we are small fish, we are tiny tadpoles in this ocean of giants that they have presenting, including Mark Piper and Dr. Nick Yiannios, who we'll be hearing from today. So that's my plug in there. You guys have to check out the AES if you can come to Chicago in 2026 February. I'll put the details in the show notes. It'll be great to see you there. Anyway, I'm digressing. I'm just sharing my excitement from learning from all these people. And what Dr. Nick has to share is pretty mind-blowing. We will answer that question of, can a patient's sensitivity be linked to their occlusion? Is occlusal adjustment indicated for sensitivity? What is the mechanism behind that? And as per the title of this episode, you will get to know the real cause of sensitivity. And once you check for caries and exposed dentine and that kind of stuff, that the most common cause of sensitivity, like leakage and stuff, like once you've accounted for that and you found that, actually this patient has no signs of cracks, there's not a significant amount of wear, there's not much exposed dentine, why is my patient saying that my teeth are so sensitive? Then the diagnosis, my friends, is likely sympathetic dentine hypersensitivity. And if you want to know what that's about, wait all the way to the end of the podcast. Honestly, it's going to blow your mind. I learned a lot from this podcast. Now, just before we dive in, it's a PDP episode, so I'm going to give you a protrusive dental pearl. Today's pearl is inspired by a webinar I gave 2 days ago on resin bond bridges. I walk through on our platform, Protrusive Guidance. I do a monthly live, at least one monthly live. And this one, it was a full walkthrough on a resin bonded bridge. I truly believe that for a single missing lower incisor, that a cantilever resin bonded bridge is the standard of care for replacing that incisor. I'm very open-minded. I'm happy to learn and change my views, but it'll take a lot to convince me that an implant for a lower incisor is better than a resin bond bridge. So anyway, I was fitting this bridge and I've got the whole thing videoed and I'm talking through it. And what I noticed is that when I'm checking the bridge on the model, I'm noticing a bit of a gap. Then I show you how to manage that, but then I transfer it into the mouth and I still see a gap. So that means it's going to be an increased cement gap. We don't want an overly large cement gap, obviously. So one thing you can do if you're unsure about the quality of the fit of your resin bond bridge is you get some light-bodied PVS. So usual runny light body stuff, you put it on the intaglio of the bridge, so basically the wing, and then you place it on. You let it set, and then you take the bridge off, and as you peel away the PVS now, you get to see how thick your cement layer or your resin layer is going to be. Ideally, you want to see a thin layer everywhere. Now, in my case, it confirmed that the wing on the incisal region had a bigger cement gap, but everywhere else it was going to be okay. So I went ahead to use my Panavia V5 and bond it, and the whole video is there. It's on the RBB masterclass. It's also on the webinar replay section of Protrusive Guidance. So if you're not a member already, check it out, www.protrusive.app. If you love our video walkthroughs, and without further ado, let's check out this episode. What is this sympathetic dentine hypersensitivity all about? Dr. Nick Yiannios, welcome to the Protrusive Dental podcast. Honestly, I was saying in the preamble earlier, I've been a long-term admirer of your work, and it's an absolute honor and privilege to have you in front of me. I've got a gazillion questions, but because of time, we have to home in on something, and the topic of sensitive teeth. I'm so excited to hear your take on it. But for those few people that haven't heard about you, like people need to go on YouTube and see your videos over the years are just incredible how you've served patients with their pain. So please give us a flavor of who you are, where you're from, and how did you get into this strange world that you practice in?
You want me to tell you a story then? Okay, I'll give you a story. Okay, so I'm almost 60 years old, so I've been in this a long time. I graduated in 93. Practiced in Dallas a couple of years. I'm in the U.S. I decided to married a girl, moved up to Missouri, which is about, 10 hours north. Practiced in a small town, got divorced, tried to build my practice, tried to get my life back in gear. I'm in the woods, basically, and this is not a wealthy community. Bass fishing is a big thing around there, things like that. Anyhow, long story short, about 2007, I'm probably your age. And I decided, back then, CEREC had just become to where you could get things done in a day, like a crown in a day. And my most frustrating part of practice was having to deal with crowns that didn't fit, contacts that were off, things like that. Margins weren't right. Once it got to the point with CEREC that I realized I could do this in a day, I thought to myself, I'm going to take this on. So I'm pretty obsessive, very kind of a type A kind of guy. I pulled in CEREC, got really good at it. I saw training by a guy named Rich Masick. Dr. Masick was in San Diego. He was the best probably in the world at the time with CEREC technology. This is like mid 2000s. Got good at that. He pulled me on his board of advisors. He had a teaching center called the Academy of CAD/CAM Dentistry. I met a guy named Robert Kirstein in one of our meetings, right? So, and Kirstein was the T-Scan guy. So digital occlusal analysis, if those aren't aware of what that is, basically instead of using articulating paper, ribbon, shim stock, things like that, you're using a Mylar sensor. USB controlled little handle, and you stick in these disposable sensors. They're about 100 microns thick, and there's inks and circuits in there, and they pick up force per unit time. So in other words, what hits when is documented, and you have a record in a Windows computer. Okay, so basically, when I met Kirstein at that meeting, I looked at him in the lecture, shook his hand, got his number, bought a T-Scan, went home, started applying that with the CEREC technology, started applying his DTR principles, exclusion time reduction.
Hello, Protrusive. Let's start with the first interjection. As you know, some episodes ago, I started these interjections because I feel sometimes you can get so deep in the episode. And for our younger colleagues or those who are unfamiliar with some of the terms that we use, it's really important to make things tangible. That's always been our mission since 2018. So let's start with what is the T-Scan and what is DTR? Right. So very simply, let's start with something that we all know, right? Articulating paper, whether you use something like inked silk ribbon kind of thing, or some type of paper, red, blue of certain microns. I like to use Parkel. It's like a 25 micron paper, the red one. It just marks so well. I also like Trofoil, which is a 12 one, but I'm digressing. Okay. So articulating paper, you put it between the teeth and it inks up, right? So you might see lots of ink marks on the teeth, right? So what's that telling you? It's telling you where the teeth are hitting or potentially hitting, because sometimes it marks up, but that's not really hitting. It's like a near miss, like it's almost hit there, but it's still inked, but it's not a true contact. But anyway, it tells you where the contact is. Now, the T-Scan is basically a sensor. It's a sensor that you put in, and what this sensor does is when you bite it, when you get the patient to bite on it, it tells you not only where the contacts are happening on the sensor, but more importantly, it gives you so much more information that ink doesn't. So what the T-Scan does, it tells you about how hard the force is. So when you see two different ink marks, it's difficult to know which is the heavier one, okay? You're only right 14% of the time based on studies. So when you use the T-Scan, it'll tell you that, oh, actually, the upper right first molar is taking 35% of the entire bite force, and the upper right lateral is taking 10% of the entire bite force, and the rest are not doing much work, right? So it tells you how much force, but most importantly, it tells you about when, tells you about timing. So for example, when we bite together, did you know that our teeth don't all meet together at the same time, right? When we bite together, you might find premolar hits first, then a canine might hit, and then a molar might hit, and then the next molar might hit, and then so on and so forth until all the teeth are in contact. So that kind of brings in the element of time. And of course, as we know, teeth don't hit in the same intensity and power. When a patient bites together, a molar might be taking a lot of the bite force. And when you put your finger on that molar, you might feel a lot of fremitus. That's like that vibration feeling that you can feel. So you know it's taking a lot of force. What the T-Scan does is basically technology hooked up to the computer to tell you which teeth hit when and with how much force. So it's like articulating paper on steroids. And for occlusion geeks like me, it's awesome, okay? It's nice to be able to measure this data. Because think about it, when we do implants or big cases, we want for there to be as much balance and harmony and distribution of force as possible, right? So that's the T-Scan. Now, we use the T-Scan in a special way to carry out something called DTR. DTR stands for disclusion time reduction. I'm going to explain DTR is. We all kind of know that when we bite together and grind our teeth side to side, in an ideal world, we would get posterior disclusion. I know that occlusion wasn't taught so well at dental school, but we all remember something about posterior disclusion, anterior guidance, that kind of stuff. That's a true philosophy or not. That's debatable. Sometimes group function can work, but some of my colleagues, like the people who are teaching me DTR, are saying that actually group function can be pathological. Anyway, I'm digressing. So back teeth should be out of the equation as quick as possible. We should get disclusion. Usually somewhere along the front teeth, like the canines, for example, they pick up the force and the back teeth are no longer in the picture anymore. Yiannios use is posterior friction, right? Think of it like speed bumps as posterior friction. So you want to get the back teeth out of the way according to this philosophy of DTR. Now, because the T-Scan can measure when someone bites together and starts grinding to the right, the T-Scan can measure how soon are the front teeth doing the work and how soon are the back teeth no longer touching. That essentially is DTR, is disclusion time reduction. So the time of them in their normal bite, i.e. their maximum intercostal position, and they grind to the right, how quickly can we get them onto their canines or on their anterior teeth, and how quickly can we disclude those posteriors? It takes a couple of seconds to do that, right? You bite together and you grind to the right, and it takes a couple of seconds for this patient to eliminate the back teeth rubbing together. So this actually means that your muscles are working overtime. And so what disclusion time reduction does is, through some adjustments and maybe some additive, like adding some canine risers, you're essentially refining the guidance, and therefore you're shortening the disclusion time. So the patient goes from MIP, you grind to the right, and you quickly get onto the front teeth, and you're no longer rubbing the back teeth together. You're no longer having that posterior friction, and that's disclusion time reduction therapy. You know, I have been seeing some of Nick Yiannios' movies on YouTube, his videos on YouTube for over years, and I was always wondering, what on earth is this guy doing? This guy's some sort of wizard. And over the years, I understood, and I got the T-Scan. Now I'm actually being DTR trained. Actually, the day this episode is going live, you're listening to this right now. If you're listening to this day one, then I'm actually being trained by Robert Kirstein right now as we speak on DTR. So now you know what T-Scan is, and now you know what DTR is. Let's rejoin the episode.
In other words, he'd been publishing for over 20 years about how when back teeth hit too long in time, this can become problematic, cause headaches, cause problems like that. You know, TMD world. And I wasn't necessarily interested in TMD world, but I was sure as heck interested in getting my crowns right. I'm just a GP trying to do good work for my patients in the woods. Mm-hmm. So I wind up noticing something that he'd never seen before. I'm starting to adjust bites per his research theory, where I'm adjusting excursive movements. In other words, when they bite down and grind off to the right or to the left, on the T-Scan sensor, you're studying 3,000 of a second increments, like what hits when, okay? So it's almost like if you're an MIP and you're chewing your food, grinding around, milling, maybe not quite touching. There's still contact happening. I want you to think the sideways excursive movements like speed bumps. The more speed bumps, the more likely the nervous system doesn't like all that extra bump, 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 bump. So you want to kind of smooth out the ride when you're going left and right. Imagine you're in a car. You want it to be a little smoother. So fewer bumps is a good thing, right? So it was based on timing. And he was talking about lactic acid, burns, all these things. But long story short, I'm applying his DTR principles in a private practice, real world. And I'm starting to notice that as I'm adjusting bites, you know, maybe they came in, they had a problem with a crown that the guy down the road did, or maybe I did the crown last month, right? And I'm using the sensor and I'm applying his principles. And I'm starting to notice they start out really cold sensitive, water and air from the handpiece. And then all of a sudden it drops down to almost nothing. But it doesn't make sense because some of the time they already had exposed dentin and now there was even more exposed dentin, but yet they were less sensitive. So I started handing people ice water. I started handing
and you were doing this like way back when, because did you perhaps start like the reason that you were doing DTR at that time was not for sensitive teeth, it was for the orofacial pain, right? Is that fair to say?
No, it wasn't even for orofacial pain. It was for me to improve my restorative. I'm like you. I'm a GP trying to serve my people. I don't want root canals afterwards. I don't want them coming back, you know, for a bite adjustment. I didn't want things like that. I wanted to be more efficient. I wanted to be a better dentist. Cervical allowed me to cut less tooth away. I could like half top a crown. I do it to this day. I mean, they're onlays, they're not crowns. You know, my margins, the majority of my margins are supragingival. And if you get really good at CEREC, you can't even see it, right? And you know, if you know what you're doing, you can get about a 25 to 50 micron tolerance. So, you know, versus 75 to 100 with lab-made stuff. You know, back in the day, we were just starting to get into, you know, some of the all ceramic things. But anyhow, I'm digressing. The point is, I started noticing that I'm adjusting bites and the cold sensitivity is going away with the water and air from the handpiece. So I started handing people ice water, had them swish, and then checked. And all of a sudden, I started throwing these up on YouTube. This is back, I don't know, 2011, 12, somewhere in there. And they were all about the T-Scan in the beginning. And initially, there was no response. No one's watching. I didn't care. I was just trying to get it out there. I'm trying to get it out to guys like you. Right. And this is,
the geeks.
Geeks. Yeah.
The nerds. But geeks when I watched those videos years ago, Nick, like it was like my headaches are gone, my joints no longer clicking. Like that was kind of, I missed at that time about the sensitive teeth. I missed it completely.
Yeah, well, the whole thing, you know, what got me into this was the sensitive teeth. So in other words, I'm just a GP. I'm not looking to be a TMD guy. I'm not looking to be orofacial pain guy. I'm not looking. So basically, I started applying these principles, noticed that as I adjust the occlusion, their cold sensitivity would go away much of the time. Not all, but probably most of the time. I called up Kirsty and I'm like, hey, what's up with this? You ever seen this? No, I haven't seen this. Well, he's a researcher. I'm a real world guy. Robert, I'm seeing this. It's real. Anyhow, long story short, a year or so later, maybe two, the YouTube videos are going up. I'm starting to get a few people looking, and it's mostly guys like you and me bashing me. How dare you touch that virgin enamel? You know, you're going to get sued. You know, you're going to perforate that crown that they did. You're going to, you know, all this kind of crazy horse crap. But, you know, and then it went kind of quiet for a while. Then all of a sudden the phone started ringing, and here's someone coming in from Malta. Here's a guy coming in from Australia. Here's a guy coming in from Canada. Here's a guy coming in from Mexico. And I'm like, what the hell's going on here?
Did you feel a lot of pressure? Did that create a lot of pressure? Because when I have someone, I'm like in South, I'm in London, right? And I get patients from like Birmingham, Newcastle. I feel the pressure. I'm like, okay, everything needs to book extra time. Everything needs to go well. It's a big thing. So for you to get these international patients, that must have been a whole new level of pressure.
It is, because you don't know, you've never met them before, never treat a stranger, right? So anyhow, I started applying the DTR stuff. I started becoming more and more, not because I wanted to, but I'm starting to see all these TMD patients because most of them will have sensitive teeth. But then I would notice that there were many times that they would have, their headaches would resolve too. So Kirstine was right in a way. There was times where it was applicable. But then, so over the years, it got to where I'm starting to see people from literally everywhere. And it's starting to almost interfere with my practice because I've got locals I got to take care of. And to your point, it's very, very hard to make time for those travelers. And you can't predict. And you've got an overhead you've got to pay. You've got staff you've got to pay. You've got a life you need to have, right? So I didn't really sign up for that. It's not what I was looking for. So
can I just stop you there? Because I'm really enjoying this, but I'm just kind of like, I'm relating a lot to what you're saying earlier in my journey to where you are, but like, you know, you very relatable what you're saying, because at that time when someone's coming so far to you, what many people may not appreciate, but I know you will appreciate and you will be able to teach me on, is the level of communication. Like my TMD patients and I are emailing a lot. There's long essays, there's emails, there's a lot of reading, there's a lot of communication that goes into, there's a lot of emotional trauma, there's stories and whatnot. So did you feel that was also like, wait, how do I fit all this in with your regular practice as well? Did you find that as well?
Well, what I did was I put up a wall. I made it to where they couldn't send me that. And it sounds uncaring. It was the opposite. I started getting into the biopack. In other words, the biopack, there's an engineer named John Radke. John and I are good friends. And back then I didn't even know him. Nowadays we lecture together. We've published papers together. He's the editor of Advanced Dental Technologies and Techniques. We just published last week. Mark Piper, Radke, myself, and a guy named Tom Coleman out of Vermont. On a new reason for sensitive teeth. We call it Sympathetic Dental Hypersensitivity, SDH. We can go there in a little bit too if you want.
We definitely will.
My point is the biopack, there's something called joint vibration where you can, accelerometers, it's almost like a headset over the joints, and the patient opens and closes multiple times, and the sensors pick up vibrations emanating from the joint.
Hey guys, Jazz here with the second interjection. This is a very quick one, right? What is JVA? It's joint vibration analysis. Essentially, it tells you how healthy or unhealthy the jaw joint sounds when it moves. So essentially, when we open and close, and if you feel your TMJ area, it should be nice and smooth, and it should be like a quiet car engine. But if you've got like a clicking, popping, crepitus, that kind of stuff, then it really rattles and knocks. And basically what the JVA captures is those rattles, and it gives you like a little graph form, so you can actually convert that to an objective data. You get these vibrations that can indicate an unhealthy joint. It's a way of tracking joint health. This is some technology that I'm not using at the moment, so it's good to get some insight into. Let's rejoin the episode.
And it gives you an idea of what's going on with the cartilage. Because I started realizing a couple years into it that I need to have objective data here. They're coming with me all these subjective things. Like to your point, they've got this long list of problems and this communication. I started realizing, no, I need to start I'm not going to talk to them until they come. I don't want to even hear why they're here. When they show up, I want to put together a protocol whereby I can objectively measure them. Okay, so this is about 2013-ish. I'm starting to realize I have to put in place a protocol. About that time, I got in my head, this stuff needs to get out there. I also got in my head that, hey, I need to stop applying DTR on everybody because I'd done it hundreds of times at that point and started realizing it doesn't always work, right? So it doesn't always take care of their headaches because there could be many things that are wrong with them. So Kirsty and I kind of split ways. We were very tight for many years, and I still love the man, and I'm not ragging him. And I started chasing a guy named Mark Piper, like TMJ surgeon, like probably Yoda. The younger the crowd here probably have never heard of Mark Piper, but Mark Piper is a badass. Excuse the language.
Best mustache you've ever seen in your life, like the best.
Yeah, he's got a heck of a handlebar, one of those, those old Western ones, but unbelievably smart man. He was at the end of the Dawson curriculum for years. In other words, if you went through the Dawson curriculum back in the 70s, 80s, 90s, and he started with Dawson in the early 80s, he's since retired about 2 years ago. He's an MD, DMD, Harvard, Vanderbilt. Okay, so physician, dentist, general surgeon, oral surgeon, ER doc. I mean, brilliant guy, and probably my biggest mentor of all time. And I've had 4 or 5, but he's number one. So I reached out to Piper. And he had a little course going on. I went to it. He'd heard of me, pulled me aside, because at the time, Kirsten had asked me to be a co-author in the textbook they'd asked him to write on the T-Scan. And I came up with the name Frictional Dental Hypersensitivity, FDH. That was the occlusion, the speed bumps, all that causing the cold, right? And I spent about a year in the literature trying to find out the reasons why, and there was no good reason as to why little speed bumps in the excursive movement would cause the teeth to be cold sensitive. He and I were talking about it, and I'm giving him my theories as we're walking to lunch the first day. And he's like, did you ever think the sympathetics? And I said, yeah, I did, but there's nothing in the literature. He goes, it's the sympathetics. So that was about 2013. So here we are, 13 years later. It's the sympathetics.
And so we got to figure out what that actually means in terms of making that tangible, right? And but what you've said there is you give some context of your history, your mentors. I love learning about everyone's journeys, and mentors is a regular theme that comes up in everyone who I admire. And it's so nice to hear who's everyone's mentors were. I'm going to just bring it back to a basic experience I experienced when I was a dental student, right? So this is probably 15 years ago. I fit a bridge. It was a cantilever from a canine to a lateral, replacing a lateral. And the patient comes back with extreme sensitivity on the canine. Now, this was a resin wire bridge. I know in the States, they're not very popular. Maryland bridges, right? They're not very popular in the States, but here they're super popular, right? And so that's when I learned that by adjusting the pontic, which was way too high in excursion. The pontics in these kind of bridges should not be an excursion at all. And that was a student rookie error. And I took it away. And then that was the first time I experienced when he came back a few weeks later, his sensitivity was completely gone. At a macro level, something that we've all done as dentists at one time or another. And then we've all experienced that, oh, the sensitivity is gone. But then the problem we face, well, not the problem, but like when we go to the lectures, when we read the books, sensitive teeth, from my understanding, based on what we're taught, is down to having thin enamel, having an erosive diet. It's a diet issue. It's a reflux issue. It's a exposed dentin, exposed tubules issue, which is rectified by let's say if the abrasion abfraction is big enough with a composite, or by rubbing Colgate Pro Relief or Oral-B, the latest version, or Sensodyne or whatever, right? And that's really what we offer our patients unanimously. 99% of dentists will send their patients off with this. And for some patients, it works. For many, it doesn't. So I'd love to know from you, from studying sensitive teeth and looking at this kind of link so deeply, so thoroughly with occlusion, with frictional dental hypersensitivity, and also now the sympathetics, can you give us dentists a understanding of the etiology and, say, pathophysiology of sensitive teeth?
All right. Yeah. Let's do it quickly, as quick as I can. So everyone's heard of dentinal hypersensitivity. Right. So I want you to think occlusal portion of the molar. And typically they're worried about exposed dentinal tubules. You've got maybe some wear of enamel to where there's some dentin exposed, right?
Like cupping. Would you say cupping, like erosive cupping,
yes,
for example?
That'll apply. And yes, it could be chemical in nature. It could be gastric regurg, things like that. It could be an acidic diet. It could be wear emanating from the joints, the orthopedic joints. Now, don't get me into my orthopedic realm, but 2/3 of the human bite's right here. 1, 2, 3/3, right? So biomechanically, the mandible's like.
So for those listening on Spotify and Apple, Nick's pointing as TMJ. So 2/3 of the occlusion is the TMJs, guys.
Yeah. So basically, I want you to think of the mandible like a door, and the TMJ is like a hinge to the door. Mm-hmm. The door has teeth connected, right? And on top of the condylar head of the mandible, you've got cartilage attached by ligaments on the lateral and medial pole. When you displace that soft tissue, that cartilage, you will very readily alter the occlusion. Okay, so it's almost like taking a crowbar to the hinge of one of the doors, one of your TMJs, bending it a little bit. Does the mandible, the door, hit the jamb, the maxilla a little bit differently? Of course it does. So the cupping, one of the possibilities, again, I'm digressed, but it could be biomechanical, it could be orthopedic, it could be, look, the bottom line is sensitive teeth, it's all a process of exclusion. In other words, you have to exclude like fractures, faulty fillings, things like that. When you go through all these checks and everything pans out, there's not a leaky crown. There's what it is.
Caries free, obviously. That's the basic things.
Free,
do the basics first.
Free, right. Dentinal hypersensitivity, the occlusal surface of a tooth, cupping to your point, exposed dentin. You're activating C fibers via dentinal tubule flow. Okay, so you've got these open tunnels that are pissing the nerve off. They're like popping the nerve, just irritating the hell out of it. There's fluid flow. The neck of the tooth, which is the majority of the time.
Can we talk about the dentine hypersensitivity just a little bit more, right? So in this scenario, if that's your diagnosis with no other source of sensitivity, what should general dentists be doing? Is it a matter of restorative, or is this the time where you say, okay, diet advice and use this sensitive toothpaste?
Well, it's the same reason on the cervical. That's why I'm going down there, and I was going to tell you. So you can have exposed dentin on the occlusal surface, open tubules. Remember, you've ruled out other possibilities. And then the most frequently you'll find cervical dentinal where you've got it where enamel at CEJ, right? Open dentinal tubules. That's going to be a different, more sharp, it's A delta, myelinated A delta fibers, basically. That's firing, that's dinging the nerve, pissing it off. But the treatment for both is the same. What I do, and it works, I'm not going to say 100% of the time because that's not fair. But if I say 95 plus, that is fair. I've been doing this forever.
Before you reveal, because we had a little chat, and what you do is very interesting, right? But Joe Bloggs, Dr. Bloggs, the average dentist is going to stick a resin in there, or GIC or a composite, okay, and give some sensitive toothpaste. And for a lot of patients, that might work. Let's face it, for some patients, that will work, right? But your protocol, I hadn't heard of it before. So please tell us, where did you learn this protocol from? How did it develop? And share it.
I spent years in the literature. I still spend time in the literature all the time. I'm reading things, I'm learning things, and I trust my eyes. I trust my hands and my eyes. And remember, I'm not an academician. I'm not looking for fame. I'm not looking for any of that. I'm looking to help the people that I serve. So when you spend that much time in the literature and you're looking for something, you're reading hundreds and hundreds of papers and you're seeing different angles. You're learning to identify that half the time what they're talking about is biased and BS. A lot of times it's funded by, no disclosures. Well, if you look deeply, Google that name and this guy's working for GlaxoSmithKline. It's like, oh, okay, there we go. Yeah. Oh yeah, you'll see this. You got to look. You can't just trust what they say in the paper. Authors declare no conflict of interest, okay? But anyhow, my point is, so how I ran into these things was that way. So the typical doc is going to want to drop desensitizing agents, oxalates, fluorides, things like that. Don't waste your time. In my world, there's a company called Photona. They make a laser. It's a dual wavelength laser called the Lightwalker. In US dollars, they're about $100,000. They're not cheap. But there's about 80 things I do with that. Okay. And I have 3 of them. All right. And I use them constantly. And it's not just for sensitive teeth. It's for surgeries. It's for healing. It's for biostimulation. It's for root canals. It's for extractions. It's for laser assisted periodontal therapy. It's, I don't want to get off topic, but the point is, basically on dental or cervical dental hypersensitivity, what you do is you spend about 30 seconds illuminating the cervical aspect or the occlusal aspect of the tooth with neodymium energy. It basically kind of, what's the word? Discombobulates the pulp. Okay. And it also theoretically starts denaturing proteins that are sitting around in the tubules, that you can't see, microscopic. Because a lot of people you'll find over time, in the practical sense, you'll see them for a checkup and they were cold sensitive, then 6 months later they weren't, even if they did nothing. Because a lot of times we'll have deposits from salivary proteins going in there and clogging up the tunnels on its own. That'll happen a majority of the time, probably.
But isn't that how also toothpaste market themselves work? And they use the chemicals to clog it up and block the pores, if you like.
Right. Yeah. So think of them like little tunnels that are open and you want to clog them. Right. So that's what they're trying to do. And that's what happens naturally out of your salivary, the stuff floating around your saliva. Well, in the times that it doesn't happen, what I do is I hit it with neodymium energy, about 30 seconds of surface. Let's say you have an abfracted area on a number, or I'm not going to say numbers because you're probably international. Upper right first premolar. Very common area. Yes. The typical spots are going to be like upper and lower premolars. Okay. By the way, occlusally related. But anyhow, my point is, let's say there's an abfraction on that upper right first premolar. I will take the neodymium handpiece and I will spend about 20 to 30 seconds illuminating it. There's certain settings that are not hard to find. They come with the laser. And then I pull out the erbium, which is a different wavelength. It's 2940, whereas the neodymium was 1064 nanometer.
And they're both on the Lightwalker. They're both in the same unit.
Dual wavelength. So you buy that one machine, you get 2 lasers, right? 2 tools. So basically then I hit it with erbium and I spend about 10 or 15 seconds per area. And in that tooth, it would take me about 15 seconds. And then I take med-grade ozone gas, which you're taking it from, med-grade oxygen through a converter, and O3 is coming out at 50 gamma, which is a concentration, and essentially kind of varnishing that shut. And 95+% of the time, that will cure them of either DH on the occlusal or CDH on the cervical. Almost always. Until such time, however, that they may wear out more of the occlusal and expose new tubules, or more of the cervical may recess, and they may expose more tubules. So you always tell the patient, hey, this is lasting. It will be permanent until such time that happens, which it is, in my experience.
But then, as you alluded to just a few moments ago, actually, well, the root cause of that, it could be dietary, it could be occlusal in origin as well. So you've got to then address the root cause as well.
Well, yeah, the dietary, for example, we talked about like proteins precipitating in and clogging the tunnel, right? In the natural sense. Well, what if an acidic environment disallows that? Right. So my point is, I know from experience for many years of doing this, that it will almost always work if it's true DH or CDH, if I hit it with the laser and the ozone. So there's your cure. Trust me when I tell you that if you're like me and you're deep into your technology, I know it sounds like a lot of money, and I'm not trying to sell Fotana. That's not my point. I don't care what brand it is. You know, if you can get a hold of that kind of tech, you can do this. Now, you can do about 80 or 90 other things that you can't do otherwise too. It's amazing tech. I'm a laser dentist too. I'm like big time into hard tissue and soft tissue lasers. Basically, erbium is hard tissue. Basically, neodymium is more soft tissue. Okay, so I literally, 70% of the fillings I do in my office, no shot, no drill with the erbium laser. And I'm not exaggerating. I will pop veneers and ceramic crowns off with my laser. The less friction, the less trauma that I induce in the pulp of a tooth, the less likely I'm to have a necrotic problem, a root canal problem, an extraction, what have you. And again, I'm starting to tip into the sympathetic realm again, because now we're starting to get into sympathetics. And I'll get there. So I'll take it from here if you don't mind. So DH, CDH, right? So another possibility is FDH. FDH would be...
Can I please, Nick, before we get to frictional, right? Because I think it's really important to just touch on this point, because what can we say, what can you say based on your experience to the dentist who is not going to get access to laser, and maybe in their country they're practicing in, it's just not going to happen in the foreseeable, right? How can they serve that patient who has dental hypersensitivity or cervical dental hypersensitivity? Is the traditional restorative routes of composite or varnish, is that a useful or an acceptable alternative?
It's not worthless, but it's not definitive generally. There are times, example, I had one this week where she had cupping, like a class 6 lesion on the top of a lower molar. And the first thing I did was I lased it. And then I used my erbium angle after I desensitized with the lasers and ozone, and I lased it to bond it. So I gave her an extra layer. I kind of sealed off the cupping after I desensitized it. And by the way, when I initially hit her with water and air on that cupping area, it was uber sensitive. By the time I was done desensitizing with the laser and ozone, it was gone. But I wanted to close off the cupping to where it wouldn't get bigger, so I dropped a composite in there. Now, had I done a composite only, maybe it would have worked, maybe it wouldn't have. So I hate to say it, but I don't have a great answer for you. If I was without that kind of tech, I would probably hit it with bonding. I would close off, I'd probably etch and bond, and I might get some longevity out of it. You know, HEMAs, things like that. Look, I used those for 20 years. You know, the last 10 years, I'm using lasers and ozone. I don't even have desensitizer in my office. I'm not kidding you. I have a very big, large practice, 7 operatories, very state-of-the-art. There is no gluma. There is no anything in this practice. We do not tell people to go get Sensodyne. We do not use fluoride. We do not use fluoride. We'll never use fluoride. That's us personally. We're more holistic.
Okay.
I don't want to get too deep into that, but...
No, that's great to know. And I feel as though we just closed off that chapter for the dentist. Like, okay, but that's great for Nick, but what do I do in my clinic? It just gives them something to think about, but we've opened their mind, because the vast majority, you know, I've heard of ozone being used in root canals before. I haven't heard of it used in this way. This is new information for me.
Ozone machines are not expensive. You're spending about $3,000. I want people to learn, in my opinion, okay, I'm not that old, but I am old. Learn to open your minds and be a critical thinker. Learn to go into the literature. Learn to spend maybe an hour or two a week. When you run into something confounding in your office, go jump in the literature and try to figure it out. Learn to identify the incorrect from the truthful. Maybe brush up on your stats a little bit. We all took it in school. You know, learn what a p-value is. Learn what a good n is. So things like that. Maybe what I'm trying to say is open the mind to other possibilities, because, example, ozone. If you jump into PubMed or Google Scholar, everyone on this audience guaranteed can get to Google Scholar. Scholar.google.com on your cell phone, on your laptop, whatever. Type it in, and I want you to type in ozone in dentistry, and you will see about 10,000 papers. And I want you to spend a little bit of time bouncing around. Example, ozone, which is supposed to be this bugaboo and it's dangerous. And I inject people with ozone gas all the time in abscesses. What am I doing? It's antibacterial, antivirucidal, anti-inflammatory. It also kills what are called prions. Remember misfolded proteins? If you, a human, which is rare, die of prion disease, you are a complete biohazard. They don't even know what to do with your body. Cremation is not enough. But guess what kills prions? Well, they're not alive. Guess what destroys prions? They're misfolded proteins. Ozone. in your life's experience, so use your critical thinking, forget the politics. After a big thunderstorm, you walk outside, you smell what? Ozone. What's nature doing? It's scrubbing stuff, getting rid of the dead stuff. What else? When the sun's out, UV, what's that doing? Destroying bacteria and viruses, right? Right. So my point is, ozone, there's massive applications. Now, if I didn't have a laser, I could grab an ozone machine for about $3,000 US. Will it work definitively? Not as well as the combination, but it'll probably work pretty well. And
hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
if you start chasing the ozone world, if you start realizing, you're going to start realizing you can start using the heck out of that thing. And it can actually make a little bit of money off of that thing. It's a very inexpensive piece of equipment. And the only disposable is you need to be able to refill the oxygen tank, med-grade oxygen. So that would be my advice. My advice would be look at the literature, get yourself an ozone machine. You can use it for all kinds of perio, endo, hypersensitivity things. That would be my advice. That's a cheap in. And I don't care where in the world you are, you can probably get med-grade oxygen if you're a health professional. And
well, that's great. I think it's good you mentioned the fact that everyone should carry out their due diligence and look at the literature. And I think that's it's very clear that even before we hit record that you have been deep into literature in many ways, and takes us nicely into the next bit, which is frictional. I think you're going to talk about frictional dental hypersensitivity, which is the speed bumps and how the occlusion has a link. And I just want to love to hear about that now.
Yeah, so basically back in the day around 2008, 9, 10, Kirsty and I were on the phone and I'm like, man, I'm adjusting bites and the water in the air. After I adjust the occlusion, it gets less and less sensitive, even though they're exposing more of the dentin. I am doing so sometimes, right? Depending on the wear patterns. And yeah, so I call that FDH and I put that in the literature. So frictional dental hypersensitivity, basically the speed bumps, the excursive speed bumps, right? So we thought initially, the best I could do in the literature at the time was there's something called an A beta fiber in the pulp of a tooth. A beta, if you have a mosquito or a fly land on you and you smack like your neck or wherever he's at, you feel it, right? Those are proprioceptive A beta fibers. They're all over the epidermis. We have them everywhere. We even have them in the pulp of the teeth, okay? So when I went to school back in the 90s, they told us that we had C fiber, A delta, and that was pretty much it. Okay, innervation wise. And so the C fiber was the unmyelinated, slow, dull pain. The A delta was the fast, myelinated pain, right? Well, come to find out, probably around 2000-ish, they started discovering histologically that they had A beta fibers, a few of them, in the dental pulp. And they were responsible for proprioception. And they were also linked up to the sensory homunculus. The sensory homunculus is that part of the brain that has that really weird, we all saw it in school, weird representation of a hemisphere of the brain, and this is the arm, this is the leg, this is the this is the that. So the A beta allowed them to add the dental pulp to the sensory homunculus. I don't want to get too deep. This is geeky stuff, but long story short, I don't believe it is A beta. I used to think it was the teeth being flexed excessively and the A beta intrapulpals.
Which is a theory I've heard as well, yeah.
Yeah, that was the theory, right? Well, it's not that. In my experience, I can tell you with almost 100% certainty it's not, based on what we've been doing the last few years with the research. Okay, so that's FDH. So theoretically, I walked with Piper at that lunch and we were talking about A beta, and that's when he looked at me and said, "Did you think about sympathetics?" I said, "Yes, but it's not in the literature." He goes, "It's the sympathetics." And I think he's 100% right. Okay, so that's FDH. So basically, if you eliminate excursive movements in the, say, the crown that you just placed on tooth number 19, they come back a week later and they're not exquisitely, let's say I drink something cold and it's a 6 out of 10 and it goes away pretty quick. That's likely FDH. If they've got the margins sealed, if everything's decent, you're not too close to the pulp, you pull out your T-Scan, if you have one, and you track force and time. Now, your next question is going to be, well, what about for the guy that doesn't have a T-Scan? Well, it's kind of like the if you don't have the laser, it might work, it might not. Articulating ribbon, this is important. Articulating ribbon, depending on the study, is about 12 to 33% accurate relative to force and time. All the big stiletto heel things that we learned about in school and all this stuff, and the 99.999% of us, all we ever use is that. If you start going to digital and you start seeing force and time in 3,000 of a second increments, it will change your world.
Absolutely.
Okay. The T-Scan will change your world, and I'm not trying to sell T-Scan either. Just like I'm not trying to
It's changed my world. It's been,
Oh, it's huge. I use it on, and this is important too. I use the T-Scan on every patient that walks in my office that it gets restorative. Every patient that gets aligner therapy, I'm getting ready to do ortho.
Same.
Yeah. I always have a record of before and after. Let's say you walked in, you're my patient, and I'm doing 2 fillings. Let's do something real basic. 2 occlusals on lower, let's say lower left, first and second molar. Okay. The first thing my girls do is they have you clench, and grind on the T-Scan sensor. So all of a sudden I walk in and I'm looking at the proper reading and I've got a record of their bite. Now, there are probably 70% of the time when I'm doing that filling for you, I'm just using the erbium laser, no shot, no drill. And then I'm having you bite and grind, checking and comparing before and after. I'm using ribbon too to mark, but I don't trust ribbon. I trust the data. The T-Scan in the literature is about 95% accurate relative to force and time across the board. 12 to 33, 95. Which one would I rather use? Most dentists are completely unaware.
Well, it's the objective data for me, Nick. I was always worried about equilibration. Like whichever definition you use, whether you're doing it to CR or just getting a bite balancing. Occlusal adjustment. Absolutely, right? And so I was worried about occlusal adjustment because, in my notes, occlusal adjustment, and then I was missing that objective data. Now that I have objective data that I had pre-op, this was the actual force and time data, and post-op, I have objectively improved the occlusion, right?
Yes.
And then no one can argue with that. And for me, that really was the license to, okay, now I can do it in a way that I'm in control.
Well, let me give you another hierarchy. Remember the door analogy with the hinges. You've got to be able to get a read on what's going on with the joint if you really want to know. Every single patient that we ever see, even their periodic exams when they come in for their 6-month cleaning, we slap the joint vibration on them, and we're comparing it to past JVA readings. Joint vibration, remember, is listening for tears in cartilage. And you can cross-reference the data with flow sheets and get an idea of the Piper classification. There's Piper's name, how deranged the joints might be. And that matters, like we alluded to that earlier. If you bend the hinge of a door, the way the door, the lower jaw with teeth connected, hits the jamb, upper jaw with teeth connected, and that in itself can be problematic. And also another thing you can track with T-Scan, let's jump back to digital occlusal. If, let's say I did those 2 fillings on you, I numbed you or I didn't numb you, I checked the after, and let's say you're cool, you didn't come back, or let's say you come back a week later, you've got a little bit of sensitivity problem to cold, the whole topic of this podcast. I'll pull out my T-Scan again and I'll check again. Maybe I missed something for about 3 or 6 or 9 thousandths of a second. Maybe there's a little excursive rub, a little speed bump, and I'll hit it with the burr, that one little spot. And then all of a sudden I'll have you swish ice water. As you walked in, you were a 7. You swish a minute later, you're a 1. I do this all the time. I've done this for...
I mean, that's so fascinating because a minute later, the upper teeth don't know what's happened to lower teeth just yet because they haven't had enough time to even meet. So do you see what I mean? Like they haven't had the time to like trial it to see for the whether it's flexure or sympathetics, which we're going to come to.
Now, yeah, you know what? Let me leave FDH for just a second and let me take you guys to SDH now.
Okay.
So you either have DH, occlusal of the tooth, where you have CDH, the cervical aspect, maybe recession, exposed dental tubules, just like you would on a DH, right? Remember, laser ozone is the cure most of the time, almost always. Or you could have FDH, which is the bite, the little speed bumps and the excursive movements. Okay. Or
okay, now again, I'm really sorry to interject, but I really need to know this, Nick. Okay, because one of the questions I need to understand, and for the sake of everyone, is when you are not sure. Okay, so I think what you're saying is follow it as a hierarchy. Look for the DH first and deal with that. Look for the CDH first, deal with that before you jump to the frictional, because there's no point then doing like adjustments and whatnot until you've actually taken care of the previous 2, right?
Yes, but here's the point. You need to have the objective metrics. I'm sorry, there's no cheap way into this. You're not going to be able to do what I'm doing with your ink ribbon. It's not going to happen. You might get lucky. You've got about a 1 in 4 chance of hitting it. Okay, so I mean, this stuff gets really deep, and I don't want to get too deep. But the bottom line is the reason I'm trying to take you to SDH is because SDH is why FDH happens.
Yeah. Let's hear about it.
Okay, so over the years, as I'm seeing people from all over the place, I have a large database. So I decided to jump into the database. I had my head assistant look, and she spent about a month in there. And we were looking for things. We were looking, because we're starting to give neck blocks. We started doing that years ago, maybe. Piper taught me this. Neck block, basically, that's a lecture in itself. But
what are you injecting?
We're injecting anesthetic, typically Marcaine 1 to 200. Basically, the upper C-spine, there's cervical sensory nerves that make their way from the neck. They cross over the sternocleidomastoid, that big bulging muscle when we turn, right below the skin. It comes very superficial. It's called the great auricular nerve. That nerve in particular is one of the ways that's a cervical sensory nerve from C2, C3 ventral that comes very superficial right by the SCM, where you can drop anesthetic about 2 millimeters below the skin. The anesthetic will essentially throw up a roadblock, not because you're trying to block the great auricular nerve, but because that cervical sensory nerve is a way that sympathetic nerve fibers make their way to lateral face and teeth from the neck. Autonomic sympathetic. So what's the point? Well, if I have a sympathetic response, I want you to just remember this one thing. Sympathetics vasoconstrict, parasympathetic dilates blood. Okay? So if I have ramped up sympathetic tone, I'm constricting blood vessels. If it's always on, they're always constricted. If I don't have enough blood flow, might I kill tissues? I wonder why that crown prep I did last week that was nowhere near close to the nerve needed a root canal this week, because you stimulated sympathetic flow.
And so this is why some good endodontists, they advocate when you're doing a deep restoration or crack, to dissect a crack, for example, to use an anesthetic without epinephrine or articaine. Oh, so without adrenaline, sorry.
That's fair. Yeah, the only reason I use the 1 to 200 is because I want it to last a while. And it's not, and honestly, the only time in my practice that I use any epi at all is when I give a neck block. Or if I'm doing, say, 8 or 10 veneers up front or something like that. Because when we do veneers, we're using CAD-CAM tech. We're doing CEREC same day. Like they walk out finished. We call that CAD smiles. We do that about every 3 months. I ship in a lab tech. He works the lab side of it and I do the preps, and we do 2 patients a day, like 16 to 20. I'll use Marcaine there. I'll use Marcaine up on the neck block. And honestly, I can use Prilocaine. I can use Cetonest plain, whatever. I can use Procaine. If I want to get really holistic and no epi, I'll drop Procaine in there. Okay. And if you understand the holistic realm in dentistry, a lot of the patients and dentists that are in that realm, they're using Procaine, which is the old fashioned Novocaine, which is supposed to have an allergic reaction every 20,000 people. I know a lot of holistic dentists and I've never even heard of one. So we're getting into that money thing again. You know, in other words, corporations pushing certain things that are more profitable. But the bottom line is Procaine, whatever. Here's the point. The sympathetics, if they're ramped up, and why might they be ramped up? Well, too many taps, too many speed bumps. Now we're pulling back to FDH, but I introduced the sympathetic idea. If I have excessive sympathetic tone, here's another thing to know. The dental pulp, if you look histologically, 10% of the nerve fibers are sympathetic, originating from superior cervical plexus, which is neck. Anyone who took dental anatomy, histology, whatever in dental school, look it up online, look it up right now on Google Scholar, whatever. I'll say that one more time, it's very important. Of the innervation of the dental pulp is sympathetic in origin. The other 90% is trigeminal. Okay? Now, of that 10% that's sympathetic in origin, some of it's sensory and some of it's motor. What's the difference? Well, afferent, efferent, right? Sensory, brain feels something. Motor, brain's telling something to do something, gland, muscle, whatever, right? So if you have sympathetic nerve fibers in the pulp of a tooth, what the hell are they doing there? And why are they coming from the neck? It's not the trigeminal. This is very important. In other words, we all think trigeminal. Our realm is trigeminal. It's V2, V3, right? Well, the reality is this is a big deal. It's going to be a very big deal probably after I die, but who knows? It takes time for these things, right? But this is important. And this is the topic of our most recent paper we published about a week ago. So Sympathetic Dental Hypersensitivity was the name of the paper. Look it up in Google Scholar, SDH. Novel etiology.
I can share it with this in the
Please do.
show notes.
Please do. And I'm dead serious. It's worth reading. The authors are myself, Piper Radke, the guy who created Biopac, and another dentist who's a kind of an expert, old school of sensitive teeth. But the bottom line is the sympathetic efferent fibers, the motor fibers coming from the neck, the reason they're there is to constrict the arterioles in the dental pulp. Now, here's the kicker. Most every other part of the body, we have sympathetic and parasympathetic nerves to counter them. In the dental pulp, guess what they can't find histologically? Parasympathetic fibers. So when you or I prepped that crown, it was an easy one, nowhere near the nerve, no cracks, no problems, just a broken cusp, no big deal. They weren't symptomatic. They needed a crown. And then a week later, they're writhing in pain. When your burr hit that tooth, you ramped up sympathetic tone. You caused excessive constriction. There's no parasympathetic to counter it. The constriction got so bad, it choked off blood flow. You get hypoxia, ischemia, potential necrosis distal to that point. So if you guys have ever wondered why it is that, good God, that was a routine filling, a routine crown. The caries was nowhere near. There's no crack, no nothing. And now I've got a root canal problem. I'm telling you what.
Okay, interjection number 3, guys. Okay, I know it was a lot to take in. So a quick little summary. That's all this interjection is, right? Remember, dental hypersensitivity. I think we can all understand this type of hypersensitivity. Typically, occlusal surfaces expose tubules, right? You blow your 3-in-1, your air on it, and it's like, oh, that's sensitive. Okay, so we can all understand and visualize that. Now, CDH is just cervical dentine hypersensitivity. Think of those abrasions, abfractions, where the CEJ is. And again, loads of our patients get that. The ones that you may not have heard of are frictional dentine hypersensitivity. Those are the occlusal speed bumps that he describes. So like posterior friction It's the back teeth rubbing, getting in the way, stimulating this nerve response, causing this hypersensitivity. So essentially, it is hypersensitivity due to occlusal cause. And now, lastly, something that was new to me was a sympathetic dental hypersensitivity, which is a nerve-driven response. Now, we're going to delve deeper into that, but remember that when you find someone, a patient who's got sensitivity, obviously, check for cracks, caries, the usual stuff first. And then once you've ruled that out, then you check, okay, is there some exposed dentine occlusally? So that's your dentine hypersensitivity. And if not, you check for abrasions and abfractions. So your cervical dentine hypersensitivity. Do you see any of those lesions that when you're blowing air near the neck of the teeth and they're super sensitive and you see those abrasion areas? Now, if they don't have that, then maybe think, could it be frictional? Could there be too many occlusal speed bumps? And if it's not that, then it's just fascinating what Nick's saying with the sympathetic dental hypersensitivity.
Why? So when you do a neck block at the greater auricular nerve, the sympathetic fibers, that's one of the main highways by which the sympathetics make it up to lateral face and ear. The auricle is the ear, great auricular nerve. It runs to the angle of the mandible, innervates parts of the parotid, parts of the earlobe, and the mastoid area. Look it up online. Look it up in Google Scholar. You will find the only thing you'll see in Google Scholar relative to dental world is stuff about wisdom teeth extractions, helping people get number on V3. And I'm telling you why, because the sympathetic nerve stuff is still active even though you've given a block. Remember, 10% of the dental pulp is sympathetic and mostly efferent fibers, which constrict blood vessels. So why we're giving the nerve block is because we're trying to reduce the amount of sympathetic flow, all right? This is how the sympathetic guys, let's call them the bad guys. This is how the bad guys make it into lateral face and the teeth themselves. It's a big deal. So here's the point. So our N was 194 in the paper, and I'd injected all 194 of those peoples, and I had a ice water swish before and after. And we're looking at their responses. And basically, there was like quartiles. I don't want to get too deep into it, but about 124 of them it affected. And there was about, of the 190, I think it was 194, 120. Yeah. So there's about 70 people where it didn't do anything. In other words,
and just to clarify now for people following along, in this study, it was the nerve block into the neck, and it was just before and after ice water, just from that one intervention, right?
Yes.
Okay.
Yes. So in other words, 124 of the 194 or thereabouts had a complete change. Matter of degrees. Some of them went down to almost zero from, say, an 8 or a 9 out of 10.
Statistically significant change.
Huge. The P was less than 0.00000000001.
Perfect.
Okay, anything less, if you know anything about p-values, 0.05 or less is statistically significant, right? Our numbers were like unbelievably significant, depending on which quartile you're looking at. So the bottom line was, here we are injecting in the neck, which has nothing to do with trigeminal, and their tooth sensitivity went away on a very large subset of those 194 people. Okay, so what does that prove? Well, does it prove anything? Well, we need controlled studies. We need people in a university setting taking this on. We need them doing like saline injections instead of anesthetics, seeing if there's a change, right? This is a clinical retrospective study. So it's the poorest. It's not a randomized control study. I'm sorry, I'm a GP. I don't have time for that.
Yeah.
I'm giving you the best I got. But the bottom line is, I can tell you, because I've been doing this for years. And there are many times where they'll come in for screening, like the TMD patient that's traveled a long distance to see me. Remember, we were talking about this about 20 minutes ago. What you do, or what I've done over the years, and I integrated and put that into my teaching center, the CNOdoctors.com thing, Center for Neural Occlusion. I created the neural occlusion screening protocols, which mean they come in, they don't even tell me why they're here. We run them through a normal, thorough dental exam. Then we send them off for MRI and CT. Then we start doing electromyography readings of various iterations. Then we do jaw tracking, kinesiology, heart rate variability monitors, things like that. All this kind of stuff, very objective data. I run them for 2 to 3 hours through all that data, the MRI, the CT, the EMG readings, the T-Scan, the this, that, the other. And then I look at them about 3 hours into it, and I'm like, so tell me why you're here. By then, they've spent 3 hours looking at the data as I explain as we go. They already have, and now all of a sudden, for the first time, they've seen where their discs are. They've seen if the bone is alive or dead. About every 6th patient, by the way, has an AVN, avascular necrosis, on average, over the years, the stuff I've seen.
High.
Oh, yeah, 1 in 6. Now, if you travel to see me from where you live, and you've been to 30 different doctors, there's a pretty good chance you've got something really bad going on, right? Yeah.
True.
So the patient pool that I've seen some stuff you would not believe. Okay. So the avascular necrosis, I literally see probably, I don't know, 4 to 5 a year.
Mm-hmm.
Now, can an occlusal adjustment fix that? No, not even close. Okay. So my point is, you have to make them own their problems. And how you make them own their problems is you give them objective data and you educate them. And then all of a sudden, that big, long communication problem that you've had over the years when you're dealing with people that live a long ways away, you shut it down. And I started throwing that out in my videos about 7 or 8 years ago, saying, Dr. Nick doesn't want to know why you're here. And people initially were kind of taken aback by that. Like, oh, he doesn't give a damn. He's just out for my money. No, I'm not. There's a reason for it, because we don't have time to go through all the subjective BS. They all told me it was in my head. And I'm like, yeah, it's probably in your head, your neck. It could be the autonomics. It could be the trigeminal or the cervical that's messing with you. So bottom line, this cold stuff led to TMD world, which I did not expect nor plan nor want. I don't want any piece of that.
See, I thought it was the TMD that led to the cold stuff, but now I'm learning your journey. There we are.
My journey was the opposite. The cold stuff, trying to be a better dentist, led to craziness where I'm starting to see people that couldn't get help. Here's the bottom line. If you can just help them diagnose themselves, you've done them a massive service. If you can objectively help them understand, you have an AVN on your left joint, you have effusions bilaterally in the joint itself, your sympathetic tone's ramped up, you might have complex regional pain syndrome type 1. You know, you're hypotonic on this muscle, you're hypertonic on that one, your disclusion times are terrible here. So what happened after I initiated a neural occlusion screening protocols over 10 years ago, only about 40% of the time maximum did I apply occlusal adjustments, because the other 60% of the time it was not indicated. What was indicated was you need to go see Mark Piper. You've got an AVN, or you need to go see the chiropractor. Your C-spine is jacked. Or you need to understand your neurologist is a little misinformed when he says complex regional pain syndrome, or RSD, old school reflex sympathetic dystrophy, which means ramped up sympathetic tone to the point where you want to put a bullet in your head. They call Cripps type 1 the suicide disease. And probably every third to fourth patient I see has Cripps. And I knew nothing about Cripps until I learned about it from Piper. So bottom line, trigeminal, cervical, sympathetic. And this all ties into sensitive teeth, because it's not just trigeminal, it's also sympathetic. So when I make occlusal adjustments, and this is what I want Robert Kirstein to hear, I want Batman to understand what I've learned over the last decade. When you have fewer speed bumps as you're making those adjustments, those excursive adjustments, every tap, 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 every bump, ramps up sympathetic tone, causing hypoxia inside the pulp of a tooth. Hypoxia causes ischemia, not necessarily a necrosis, but ischemia to the point where it's kind of hyperpolarized. And all of a sudden that cold insult is just like unbelievably bad. When you get rid of some of those speed bumps and you decrease the tap, 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 which ramped up sympathetic tone before, and now there's fewer taps, it's not about timing. Because in my opinion, you cannot reproducibly do that. On the T-Scan, there's a center of force icon. It's like a little kite. When you bite down, you see this little graphical depiction. And when they clench, you'll see that kite hold real still. And then you'll have them make a right excursive movement, and the kite will start floating off and zinging around. Straighten that line. When they're going right, make it go towards the upper right, nice and straight. All you got to do. The timing will be different. Patients if they have dystonia, if they have problems like that, they're going to be slower, faster, this, that, and the other. I love Robert and I love his research and the disclusion time and all this. But in my experience, I'm far better chasing the center of force icon. I want to straighten that line. If I straighten that line, which is the path of breadcrumbs, whereby all the average force percentages at that given moment on the graph, when I straighten that out, that's when the magic happens. In my world, I don't even look at timing.
Okay, interesting.
Okay? I'm getting too deep because most of the audience has probably never even seen a T-scan.
But this is just gives us a flavor of how much there is to learn and how much to know. I mean, you've already spoke about the fact that if you're relying on articulating paper, you're relying on what is largely false data or rather missing data, right? We think the big mark or the small or the bullseye is indicative of force, but it isn't, okay? And a very low percentage of time. We know that. We've discussed it. In fact, Rob Kersey was on this podcast. So we titled that podcast episode, Articulating Paper is Lying to Us. And that was a good one. But what you're building on here with relation to tooth sensitivity, for me, is very new. All these protocols you're suggesting, but also this input and involvement of a sympathetic. Let's talk about the final bit now. Only got a few minutes left, but in terms of narrative, right? There are different narratives, Nick. Like, for example, some academics or some theories of TMD is it's very much emotional, it's stress related, the occlusion is irrelevant, anatomy is so much irrelevant. So the biopsychosocial with the emphasis on the psychosocial.
Yep.
Then there's our friend Rob Kirsten, who teaches me that, you know what, a lot of these, if you do the imaging and the joints are okay, then, you know, a lot of these issues are, occlusal, okay? And if you fix the occlusion, you get that disclusion time reduction, you get that time below, 0.3, 0.2, whatever it was for that individual, then with the correct EMG data, and then you will cure that patient, right? What would you say is your narrative and your legacy?
My narrative, my legacy. Well, the biopsychosocial
today, because things are always developing. As you've said, and I really respect about you, is you said that at once upon a time you thought this about the flexing of the tooth, and now you think different. And I admire that about
open. My mind, I could be dead wrong, but the data, you've got to chase the data. You got to trust your eyes. So if I read something and I try to vet it as best I can, make sure there's no conflicts, and I try to apply said research or results or what have you in my practice, if I'm not seeing that, either I suck or I've done something wrong. Now, the biopsychosocial thing, you know what that is? The autonomic sympathetics. This is deep. Now we're getting into deeper neurology. I want your audience, open up that Google Scholar, and I want you to see how the autonomic sympathetics affect the pineal gland, melatonin. I want you guys to look into that. So the next time you start hearing this biopsychosocial stress thing, well, I want you to think sympathetics. I want you to think hypoxia. I want you to think melatonin levels. I want you to look for yourself. And then I want you to maybe learn how to do the neck blocks. Come to the Center for Neural Occlusion. This is not a sales pitch. This is my passion. This is not a moneymaker. Trust me. We're lucky if we break even. Yeah. My wife always reminds me I need to quit this, but I'm not going to. My point is, I'm sorry, I love it. I'm passionate about it. And let me tell you why I'm passionate about it. 2 reasons. It makes me a better dentist. And if you've seen the kind of patients that I've seen with the kind of problems they've got, and you're able to at least help them figure out what the heck's wrong with them, that's when you get your endorphins rushing. That's when it doesn't matter. That's when you're really there for the right reason, that you've actually accomplished something. So what's my legacy? My legacy would be to pass what I've learned on to others and hope they will take it up and prove me wrong, prove me right, learn, spend some time. A lot of doctors will go out and they will, and I think it's great, they'll go volunteer their time in Africa. They'll go on a mission trip. How I give back is this: the videos, the research, the publications. It's all thankless. There's no money. I get paid when patients come to see me, but it's the least profitable thing we do. My wife reminds me of that all the time too. Love her for it. But I'm not quitting because I'm passionate about it. Because when you can literally change people's lives, which I've done innumerable times.
I've seen it. It's been brilliant to see your videos over the years.
Then there's times where you can't. But at least they understand why, based on my limited understanding of their set of problems, because it's never one thing. All right. Last thing that I should get into real fast. There's a concept called the beaker of pain. I call the beaker of pain this: like you or I sitting here right now, our masticatory system, our somatic system is not problematic. You and I aren't hurting. We're not thinking about our pain in our jaw or our headaches, right? So our beaker's likely not empty. The point is, when the beaker fills up and it overflows, that's when we're seeking help. But there's lots of things filling the beaker. It could be a neck problem. It could be a bite problem. It could be a tooth problem. It could be a muscle problem. It could be a sympathetic problem. It could be a psychological problem, pineal gland. It could be a whatever, right? So my goal when I screen people is to try to understand what the hell's in their beaker. They're in my chair. They're obviously overflowing. I have to try to diagnose as much as I can. There's going to be 10, 20, 30 things in that beaker. I need to objectively identify as many of those that I possibly can. I need to take whatever I can do treatment-wise as a dentist, turkey baster, suck that up to where it doesn't overflow anymore. There are times where the occlusion is enough of that beaker. When you suck it out, they're not thinking about it anymore. They're walking around like you and I.
I work with a TMJ physio. Her name's Krina. I'll give her a shout out. And she talks about it in the form of a bucket. And so say the same thing as saying there's so much filling their bucket, and it's about how can we help reduce the bucket. And so it's great that you mentioned that. It's a great point, because it's never just one thing. Absolutely.
The bottom line is understand there's a beaker of pain, a bucket of pain, whatever you want to call it. Understand they always have multiple problems. Understand the top three are trigeminal, cervical, sympathetic. Learn these guys. We already have a pretty good handle on trigeminal. We suck at necks, and we know absolutely nothing about the sympathetics, the average dentist.
Until now.
By the way, the sympathetic stuff brings us big time into medicine.
Yeah.
This is our realm. And I'm ready for the day my medical board in my state may say, why are you sticking people in the neck? I'm totally ready. Put me in front of whoever you want. The neurosurgeon, I don't care. I'm ready. Yeah.
Hello, geeks. It's the fourth and final interjection. And I use that word geek intentionally because if you've made it this far this episode, oh my goodness, you are a geek. This is one of the geekiest episodes we have ever done. And wow, just well done for making it this far, right? So I actually forgot to ask him a question, and I emailed him. I said, one thing I didn't get to ask is, the greater auricular nerve block, if it reduces the sensitivity, thus it kind of points to a sympathetic etiology, right? So it's a sympathetic dentine hypersensitivity, right? So if you give those neck injections and they swish ice water and they're completely fine, that points to the etiology, right? But once the block wears away, the sensitivity returns. So I asked, what's the long-term fix for these patients? So what he told me is the dentine hypersensitivity, the cervical dentine hypersensitivity, to remember the occlusal and the cervical, and the frictional dentine hypersensitivity, they usually have definitive fixes, okay? But you can't always cure the sympathetic endotype. So sometimes the cure is occlusal corrections, he says, even for the sympathetic dentine hypersensitivity. And for those ones, you have to vet the orthopedic. So you have to make sure that the joints are healthy or adapted, and they need bilateral, stable or adapted joints before you do any occlusal correction. So like MRIs and CTs. And sometimes the etiology actually arises from the C-spine, and sometimes the etiology is further down the spine, because sympathetics can arise from T1 to L2. So sometimes the damage and injury is somewhere along the sympathetic pathway, and that can be the cause. And sometimes the etiology is just a ramped up sympathetic tone, and it's a combination of the above. And therefore, this sympathetic dentine hypersensitivity is the least predictable to fix. Now, isn't that just absolutely fascinating?
And by the way, there's precedence in the literature by yours truly about the neck block. Multiple papers now, chapters in textbooks, and we're going to be publishing more and more and more and more. And it's a huge deal. And if you jump onto the YouTube channel, type in Dr. Nick DDS on YouTube, you can start seeing, especially the last year or two, you'll start seeing some really strange stuff, the cold stuff, this. If you look back 5 years ago, it's big MRI stuff. You look nowadays, it's big sympathetic stuff. And by the way, last thing, you joined yesterday. Facebook, I am not promoting Facebook, don't really like Facebook, but we've had a forum on Facebook for over 10 years now. Center for Neural Occlusion. It's a private one. There's also a public one. Don't join that. You can if you want. The private one is for doctors only. Highly recommend that we all come together and ask each other questions. And one of these days, if the CNO ever grows, in my retirement, I might spend time on it to make it grow. I'm planning on having my own dedicated website, my own forums where people like you and me can like interact and ask questions and, you know, try to learn from one another. So that's.
Well, I'll put the link to that. I mean, I've been on it for a short while. I mean, there's some hidden video stuff on there if you like, right? And it's incredible. Honestly, what you've done with patients and what I'm seeing has been great. It's been great to learn from you. I'm looking forward to that next paper they're going to write as well, and I'll be able to share the paper that you have. And what you mentioned towards the end is about the integration to medicine, how this unlocks that. Well, it greatly brings together the AES conference in February, where you'll be speaking as well, the oral physician. And I just really want to plug that really hard, because it's thanks to the AES who's connected me with you and Danny and Tamimi and all these great guests I've had on. And so I know
Daniel's mentor, Hatcher, he's part of the CNO.
Yeah.
He's like a badass oral maxillofacial radiologist, one of the best in the world. At least he used to be. He's not active anymore. But when I formed the CNO, we formed a board of advisors, not directors. And we've got like TMJ surgeons, med radiologists, maxillofacial radiologists, periodontists, orthodontists, GPs, researchers, blood guy, Rick Myron, if you've ever heard of him, the PRF guy. You need to interview him sometime. He's the guru. PRF,
Okay.
platelet-rich
Sweet.
fiber.
Yeah.
Amazing.
I've heard of PRF in surgery and wound healing and that kind of stuff, implant world, but don't
This
know much
guy's
more about it.
published 10 textbooks and 350 plus publications on that topic.
Amazing.
Yeah, Rick Myron. Yeah.
So watch out, guys.
I'll
Coming
connect
soon
you
on
with him if you
Protrusive.
want it.
Yeah. I'm always, like I said, I'm a sponge, right? I'm here to share. So just for final things, I'll look forward to meeting you in February in Chicago. And I want to encourage as many colleagues to come to that as well. And obviously the websites, CNO, everything, I'll put in the show links. And the Facebook group is probably the best way for someone to connect with you and show some
Quickly,
love or debate
totally
and discuss,
free,
right?
Totally easy. Yeah, it's
Yep.
And you have to wait for me to let you in. You know, we ask, are you a medical or dental professional? Just answer the questions. Because a lot of times we'll have patients trying to sneak in and nope.
Yeah, I can
This is
imagine.
just for us. Yeah.
I can imagine.
And by the way, on AES, the way I understand it, Mark Piper says this is his last time to lecture. So you better show up. And here's another quick tip on Mark Piper. I want you guys to jump on YouTube and I want you to type in Dr. Mark Piper, AACP, American Academy of Craniofacial Pain. I want you to learn from the best in the world, in my opinion, on this stuff, on the sympathetic angle. I'm his student. He taught me, and I still have 1,000 times more to learn before I can get to his level. I filmed that when he and I spoke at the American Academy of Craniofacial Pain back 7 years ago. He hit them with the sympathetics and CRIPS, complex regional pain syndrome, and then I followed with practical stuff in occlusion world, dental world, okay? Specialty GP stuff. But that one lecture, I've listened to it probably at least 10 times over the years.
Amazing.
Every
I'm
time
gonna stick that on. I can't wait to watch it and stick it on 100%.
That's worth your time.
It'll be made available to all the what we call the Protruserati. Nick, absolutely a pleasure to host you and speak with you. Learned so much with our short time together today. I can't wait to learn more from you over the years. Keep doing what you're doing, please. Right, keep doing what you're doing. And see you in Chicago next year, my friend.
Thanks, man.
Well, there we have it, guys. How fascinating was that? I really appreciate you listening all the way to the end. Big shout out to Dr. Yiannios. It was a complex topic and like this guy knows so much, and I always notice that with my guests who just know so much, it's often difficult to get the right bits across. So hopefully together I was able to interject at the right times. I love him for his storytelling and the admission of the fact that, you know what, he changed his views and theories and he's amenable to changing your mind and how something works, and he thinks very critically. And I think we can all learn from that and appreciate that. Anything that was promised in this episode, the team try their very best to put it in the show notes. If you are watching this on Protrusive Guidance app on iOS, Android, or on the web, scroll down, answer the quiz, get 80%, and we will send you a CE certificate. We are a PACE-approved education provider. I'm going to thank my team for the hard work they do, and one more request, Protruserati, have you hit the subscribe button yet? If you haven't, it really does help us to get more reach, to attract more guests in the future, and to keep doing what we're doing. So don't forget, wherever you're listening or watching from, hit that subscribe button. Thanks again. I'll catch you same time, same place next week. Bye for now.